Chapter 24. Neurodevelopmental Disorders. 1. Neurodevelopmental disorders. At school, most children are required to master a core curriculum. Some are unable to meet any demands of their school system, others learn, but only with difficulty. Some repeat one or more grades, some graduate but fail to master certain subject areas, some even graduate without mastering basic knowledge in any area. For those who fail to learn, the educational experience leaves emotional and attitudinal scars. These scars may persist throughout life. Non-neurodevelopmental causes. By no means are all causes of learning difficulties that children encounter in school neurodevelopmental. A child may be disturbed by an unhappy home life, be enduring abuse, be bored by school, dislike a teacher, have a physical handicap, brain dysfunction or brain damage. The difficulty could also result from brain dysfunction or brain damage. School system capacity. Some school systems are equipped to assess and distinguish the causes of learning problems. Most have no resources for either assessment or remediation. Even when a school is unequipped to deal with learning problems, if a child is not learning effectively, the question of cause will arise. The question is whether the cause is brain damage, dysfunction, or something else. Neurodevelopmental disorders. Formal definitions of neurodevelopmental disorders encompass a wide variety of school-related problems. These include problems in interpersonal skills, problems in intellectual achievement, difficulty in school, dyslexia, because reading is central to success in school, inability to read is central to the study of neurodevelopmental disorders. Dyslexia comes from the Greek dys, for impaired, and lexia, for word. The World Health Organization, 1992, defines dyslexia as a disorder manifested by difficulty in learning to read despite conventional instruction, adequate intelligence, and sociocultural opportunity. It is dependent upon fundamental cognitive disabilities. These disabilities are frequently of constitutional, mental or physical, origin. Historical background and evolution of understanding. Origins of dyslexia, aphasia, and early theories. Dyslexia emerged within the context of aphasia. Aphasia is the loss of language ability resulting from brain injury. James Hinchelwood, 1895, is a Glasgow eye surgeon. He proposed that prerequisite brain areas were absent or abnormal in students who could not learn to read. Pringle Morgan is a general practitioner in the English town of Seaford. He made the same proposal independently the following year. It seemed logical to conclude that developmental dyslexia is similar in nature to acquired dyslexia. Developmental dyslexia is acquired before birth or during early post-birth years. Acquired dyslexia is due to brain damage after the person has learned to read. Learning deficits in other spheres, such as mathematics, also would be due to some underlying brain problem. Orton's contribution. Samuel T. Orton, 1937, proposed that dyslexia is due to delayed function, not anatomical absence. It was correlated with left-handedness, tendencies to reverse or invert letters and words when learning to read or write. He termed such dyslexia strephosymbolia, from the Greek, meaning twisted symbols. The non-dominant hemisphere, usually the right, was excessively dominant or not sufficiently controlled. Reversed images of things. Education could establish normal dominance of reading in the left hemisphere. Education could resolve the problem if an instructor was clever or persevering. When sociologists and educational psychologists became interested in learning disabilities, many supposed that environmental explanations accounted for learning impairments. Many did not suppose neurological explanations accounted for learning impairments. This stance was perhaps motivated by the hope that environmental causes could be reversed more easily than neurological ones. Learning disability. The term learning disability originated in an address given by Samuel A. Kirk in 1963. He argued for better descriptions of children's school problems. He excluded children with sensory and mental disorders from the group he labeled learning disabled. Members of Kirk's audience were influenced both by his address and by his definition. Later joined together to form the Association for Children with Learning Disabilities, further popularized the expression he had coined. The American Psychiatric Association's 2013 Diagnostic and Statistical Manual of Mental Disorders, DSM-5, adopted the term neurodevelopmental disorder. Proliferation and shifts of terms. Edward Fry, 1968, emphasized the overabundance and consequent confusion and inaccuracy engendered by the wide variety of terms long used to label learning disorders. Edward Fry published a tongue-in-cheek do-it-yourself terminology generator from which about 2,000 labels can be constructed. From time to time, terms in wide use may take on pejorative connotations and be dropped in favor of new terms. The DSM-4 formally defined the term retarded as certain low scores on IQ tests. The term retarded is absent from the DSM-5. Advances in neuroscience and diagnosis. Improved understanding of brain function and methods. It is proposed to result in improved diagnoses of neurodevelopmental disorders related to symptoms and their treatment, methods, behavioral testing, brain imaging, identifying brain regions implicated in learning difficulties. Neuroscientists now recognize that a person may display selective impairments in, say, music, mathematics, or spatial navigation alongside otherwise healthy and even exemplary behavioral function in other areas. A variety of factors in early life contribute to brain health and consequently to adequate learning adjustments. Types of neurodevelopmental disorders. Types of neurodevelopmental disorders. The classification and incidence of neurodevelopmental disorders correspond to the emphasis placed on communication disorders, on self-control, and on certain academic specialties in most public school systems. Disabilities can interfere with acquiring, reading, spatial orientation, mathematics, acquiring social skills. Symptoms associated with neurodevelopmental disorders: hyperactivity, perceptual, motor impairments, emotional lability, general coordination deficits, disorders of attention, short attention span, distractibility, perseveration, impulsivity, disorders of memory and thinking, specific learning disabilities, including especially those of reading, dyslexia, arithmetic, writing, and spelling, disorders of speech and hearing, neurological signs and irregular EEG. 2. Learning disorders that affect reading. Learning disorders that affect reading, skills required for reading, letter identification skills, phonological skills involve converting letters into sounds by using certain rules, grapheme association skills involve using the visual gestalt of a word to access a previously learned sound. Sequencing skills involve a number of sounds that are analyzed and combined in sequence. Short-term memory skills are needed to retain pieces of information. These pieces of information are sequentially extracted from written material. Acquired information includes lexicon, a memory store that contains words and their meanings, knowledge of combinations, knowledge of the ways in which words can be combined, associated ideas, information about the ideas with which words can be associated. Types of reading. Reading is mastered in either of two ways. Phonetic reading. The first way is phonetically, by decoding the sounds of words. Phonetic, or phonological reading, converts a letter or group of letters into sounds, phonemes, that cue the meaning of a word. The sounds achieved by analyzing letter groups lead to a pronunciation. The pronunciation then accesses the lexicon for the word's meaning and connections. Graphemic reading. The second way is graphemically, by using the image of the word. To access its sound, in graphemic reading, also called lexical or whole word reading, the word is memorized. Many English words are irregular and must be memorized. Graphemic reading is also how Arabic numerals 1, 2, 3 must be read and learned, how international symbolic road and direction signs must be read and learned. Integration of reading strategies. Fluent reading thus requires both strategies. After learning to read phonetically and becoming fluent, readers become more dependent on grapheme. Short-term memory deficits. Some people may not make proper sense of written material because they quickly forget words and phrases as they proceed. This type of disability may be particularly obvious at older ages, when reading material becomes more complex. Long-term memory deficits. People with poor long-term memory may not understand the sense of words despite good decoding skills. They may not understand the words simply because they do not recall information about the words. Meanings. This situation is similar to that faced by a person who speaks only English trying to read Italian. She can sound out the words by using general phonetic rules, but not knowing what the words mean, she cannot understand what she is reading. In fact, people with dementia often behave in this way. They can read, but they understand nothing. Lack of uniformity. Further compounding the understanding of the causes of learning disabilities is lack of uniformity in the teaching of reading. The disagreement between advocates of initiating reading instruction with phonological reading versus graphemic, or whole word, reading has been referred to as a war. Scientific and technological approaches. Carol Connor and co-workers, 2014, suggest that more scientific approaches to reading, such as algorithm-guided individual instruction, can maximize the benefits of both systems. This approach emphasizes building skills via individualized assessment and instruction. The algorithm approach can capitalize on new technologies including e-readers. E-readers allow users to vary print size, font type and size, and line length, to vary letter and/or background color, can provide word pronunciation at a touch. Causes of reading disorders. Language plays a high-level role in managing our mental processes. Language is affected by other behaviors. Language also affects other behaviors. Variability of dyslexia symptoms. People with dyslexia exhibit a wide range of symptom clusters and also individual variations. These include deficits in attention, eye movement, brain development, memory, coordination, spatial abilities, movement sequencing, map reading, visuospatial processing. Theories on causes of reading disabilities: the phonological theory, the attention theory, the sensory theory, the motor theory. Phonological deficiency, phonemic awareness deficits, impairments in language and reading may stem from children's difficulties in consciously decomposing words into their constituent speech sounds. This ability is called phonemic awareness. Early investigations of sound categorization. An early investigation describes the sound categorization ability of children who have not yet started to read. Children were given 3 or 4 words. They were asked to pick out the word that does not have a sound, phoneme, in common with the others. Examples of sound categorization tasks. In the series hill, pig, pin, hill is the correct choice. In the series cot, pot, hat, hat is the correct choice. In the series pin, bun, gun, pin is the correct response. Later reading and spelling outcomes. When the same children were older and had started to learn to read, those initially weak at sound categorization later fell behind in reading and spelling. This outcome argues that the initial insensitivity to rhyme and alliteration causes subsequent reading impairment. If a child who was initially impaired was given special training in rhyme and alliteration, his reading was far less impaired after reading training began. Brain imaging evidence. A meta-analysis of brain imaging studies suggests that impairments in phoneme use and recognition are associated with language regions of the left hemisphere. According to this view, reading impairments stem from impairments within the brain's language processing systems. Attentional deficiency, non-language-related problems. Some theorists propose that reading impairments can stem from problems not directly related to language use. Impairments in separating stimuli have been found in all sensory modalities in reading-disabled people. Impairments in producing movements have also been found. Difficulties in sensory separation and motor control. Language-impaired persons may require longer intervals between stimuli before they can detect 2 separate lights or 2 separate touches. They may be impaired in producing rapid movements, difficulties in auditory processing. They may also be impaired in sound frequency discriminations, detecting a target sound obscured by background noise. Attention hypothesis. The attention hypothesis suggests that the central problem could be sluggish attention shifting. It is attention to and selection of a letter and not the identification of the letter and its associated sound that contributes to dyslexia. Neural basis of the attention deficit. The suggestion is that the problem arises in the parietal lobe association areas. These areas receive input from all sensory systems. These areas then initiate movements, including eye movements during reading. Consequences of attentional deficiency. Such an attention deficit leads to an inability to switch attention. It affects many sensory domains. It produces reading impairments. Sensory deficiency. General sensory impairments. Because reading depends on detecting words both visually and orally, sensory impairments have been examined in association with reading disabilities. People with dyslexia reportedly have no difficulty hearing speech in quiet conditions. They do have difficulty hearing in speech-noisy conditions. This suggests that they are impaired in sensory discrimination. Auditory processing deficits. Detection of rapid successive sounds. Paula Taulal and her co-workers examined the sensory detection abilities of children with learning disabilities. They found them impaired in detecting sound events that take place in rapid succession. If two tones are presented in succession very quickly, impaired children will hear them as one tone. If the interval between the tones is gradually increased, a point will be reached at which they are heard as two tones. 4. Most people, a separation of about 10 to 40 milliseconds is required before two tones are discriminated. For some people with reading disabilities, a much longer separation is needed. Relevance to language impairments. This finding's relevance to language impairments is that stop consonants, ba, da, ga, pa, and ta, contain a transition period in which the sounds change very rapidly, usually within 40 milliseconds. When stop consonants are used as stimuli, reading impaired people have difficulty differentiating one consonant from another. They have no difficulty in detecting vowels. They also have no difficulty in detecting stop consonants if the transition period is lengthened. A detection difficulty in infants is predictive of later language impairment. Remediation approaches for language-related disorders. Training in sound discrimination. Taulal and co-workers suggest that remediation of language-related disorders should focus on training in sound discrimination. For example, they reason that if a child has difficulty in discriminating da from da when the sounds are presented at a typical rate, then first slowing the presentation down so that the sound's durations are dragged out makes the discrimination easier. Computer-based interventions. Taulal's group constructed computer games called Fast Forward in which subjects, who are rewarded each time they make a correct discrimination either between verbal or non-verbal stimuli, gradually work their way from simple to more complex discrimination problems. They also designed computerized listening exercises that teach phonological discrimination using acoustically modified speech. The computer-based exercises measure each subject's initial performance level. They then lead the subject through extensive daily training for several weeks. After the training, the subject's performance level moves closer to standard. Training in sound processing rates improves temporal integration on the discrimination tasks. Magnocellular visual theory, visual motion deficits and reading. The magnocellular visual theory is similar to the auditory sensory theory, except it postulates that reading deficits originate in the magnocellular part of the visual system, which processes black, white vision and movement. If a child's detection of visual motion is disturbed, he or she may have difficulty reading because the words on the page appear to jump around. The magnocellular theory suggests that if children read through a color filter or with only one eye, their perception of word movement can be reduced and reading can be improved. Neural evidence from imaging. Using fMRI imaging of V5, the motion processing area in the dorsal stream, Alyamide and colleagues also conclude that activity in V5 is sluggish in poor readers. They argue that poor reading is causative and not the result of impaired magnocellular activity. Motor deficiency, cerebellar theory of reading disabilities. Introduction to the cerebellar theory. One motor theory of reading disabilities is the cerebellar theory. The cerebellum is classically associated with movement. The cerebellum also participates in higher cognitive functions. These include timing, coordination, and attention. These skills are relevant to reading. Potential effects of cerebellar damage. Cerebellar damage in adults does not abolish any language skills. If tests sensitive to higher functions were administered, the cerebellar theory proposes that impairments might emerge. The role of the cerebellum in language and reading, language impairments, and cerebellum dysfunction. No agreement exists with respect to the cerebellum's precise role in language. Its dysfunction should be expected to impair language learning. Reading requires rapid sensory processing and attentional shifts. The cerebellar theory proposes that cerebellum dysfunction in these respects should be reflected in reading impairments. Alternative view: cerebellar abnormalities and dyslexia. Catherine Studley and John Stein reviewed the evidence supporting a role for the cerebellum in dyslexia. They argue that abnormalities in language networks include abnormalities in the cerebellum. They argue that cerebellar abnormalities are not causal for dyslexia. Theories and evidence for learning and reading disorders. Among the remarkable number of causative theories of learning disorders in general and of reading disorders in particular, many are supported by substantial experimentation. Many are supported by tests sensitive to the relevant deficits, brain imaging and autopsy studies. A parsimonious interpretation of this widely ranging evidence is the likelihood that subpopulations of disabled readers display different deficits. Multi-causal approaches. Ramus study on reading disabilities. Study design. Frank Ramus and his co-workers attempted to evaluate all of the theories in a single study. They gave a small population of 17 disabled readers an extensive series of cognitive, sensory, motor, and reading tests. Key findings. The investigators found that their subjects all had language impairments in the use of sounds. A subset of subjects had sensory deficits in both the visual and the auditory domains. A second group had motor deficits. Of these subjects, most also had auditory deficits. A third group had language deficits with neither sensory nor motor symptoms. Interpretation. Ramus and colleagues suggest that the major cause of reading disability lies in language processes stemming from language-related brain areas. Other areas related to attentional, sensory, or motor function may additionally be impaired and contribute to the disability. Genetic perspectives on dyslexia, multi-causal view, and chromosomal research. In keeping with a multi-causal view of reading disorders, Amaya Carrion-Castillo and colleagues summarize research on 9 different regions of 9 different chromosomes on which gene mutations are suspected to be involved in dyslexia. Candidate genes in any of these regions, when identified, will likely contain many mutations. Gene identification and longitudinal studies. Research directed toward identifying genes in these regions and their specific effects on reading are aided by longitudinal studies on individuals at risk for dyslexia. For example, the Dutch dyslexia program, Van der Leij and Maassen, follows 300 children at risk for dyslexia. The program facilitates genetic comparisons of children who acquire dyslexia and those who do not. The program also facilitates correlating specific reading deficits with individual genetic results. Neuropsychological evaluation. Core assumptions of assessment. Assessment approaches to dyslexia rest on the assumptions that the neuropsychological test can identify impairments. They also rest on the assumptions that the neuropsychological test can suggest strategies for remediation. Neuropsychological testing strategy does provide a comprehensive evaluation that is useful for counseling. Neuropsychological testing often is favored because it provides evidence that a neurodevelopmental impairment is causative. It also provides evidence that extra instructional resources are required. Scope and function of neuropsychological testing. Breadth of evaluation. Neuropsychological testing assesses performance on a wide range of tasks. It provides insight on all areas of brain function. Associated symptoms in learning disabled children. Most learning disabled children are not dyslexic or dyscalculic, unable to do math alone. Rather, they have several associated symptoms. Teachers and parents may be unaware of these associated symptoms. Discovering these associated deficits helps the adults in a learning disabled child's life to understand the difficulties with which the child is struggling. Differential diagnosis. Neuropsychological tests can also help distinguish between children who have central reading impairments. They can also help distinguish between children whose problems have emotional or social causes. IQ testing and dyslexia. Research focus on WISC subtests. Many studies focus on the IQ subtest results of learning disabled children. These analyses attempt to correlate learning impairments with performance on the subtests of the Wechsler Intelligence Scale for Children, WISC. Figure 24.2 presents a compilation of the results from studies in which a total of 1521 reading-disabled children and 554 control children were tested and compared. Acid profile and IQ patterns. The dyslexic group displays low scores on 4 subtests: arithmetic, coding, information, and digit span. This acid profile is typical of many such studies. Dyslexic children characteristically have an overall IQ score that averages about 7 points lower than the same score attained by control children. Their mean IQ score is roughly 100. Children above age 8 show the acid profile. Children younger than May 8 not show a deficit in the information or arithmetic subscales because they have yet to acquire information or arithmetic skills. Although the deficits in digit span and coding are commonly seen with dyslexia, there is no agreement that these deficits are necessarily related to a reading disorder. Variability in IQ scores. Differences in verbal and performance IQ. Many researchers have commented on the wide differences between verbal IQ score and performance IQ score in persons with dyslexia. Recall Ms. P.S. results. Some experts believe that 2 types of dyslexia can be identified on the basis of these scores: subscore variability and interpretation. Generally speaking, the subscores of a child with dyslexia vary greatly. The child will score in the high range on some subtests, the low range on others, the average range on still others. Nevertheless, for an experienced counselor, a pattern displayed by any child may be meaningful. Age-dependent test differences. Group comparison on composite test battery. In a comparison of the performance of a dyslexic group with that of a control group on other sections of a composite test battery, other tests that also discriminate between the 2 groups depended in part on the person's age. This age dependence is particularly evident in 3 tests: left-right differentiation. In a test of left-right differentiation, Figure 24.3, neither children with dyslexia nor age-matched control score above chance if they are younger than 8 years old. After age 8, the control children perform well. The children with dyslexia continue to perform at chance. Word fluency. Another emerging difference appeared on tests of word fluency. For example, give as many words beginning with the letter S as you can. Dyslexic and control scores are similar in children younger than 8 years. The scores diverge increasingly in older age groups. This suggests that fluency performance in the control group improves with age. The dyslexic group's fluency remains almost static. SEM's body placing test. A third pattern was obtained on the SEMS body placing test, another test of left-right discrimination. Significant group differences emerge only in adults. These differences depend on the fact that adult control's performance on the tests was virtually perfect. These observations suggest that the tests can be applied with some success to children. They must be interpreted with caution in younger children. Retesting at different ages is worthwhile. Supplementary testing for dyslexia, functional impairments, neuropsychological tests with the objective of investigating learning disabilities must be accompanied by specific tests of functional impairments. In examinations for dyslexia, reading tests should also be given. Additional tests, many supplementary tests also can provide insights into specific aspects of learning impairments. 3. Non-language neurodevelopmental disorders. Non-language neurodevelopmental disorders. Children have difficulty in comprehending aspects of their environment, pretending and anticipating, interpreting others' facial and emotional gestures, and performing skilled movements. These disabilities can seriously compromise independent living in adulthood. Attention deficit hyperactivity disorder. Core characteristics. Attention deficit hyperactivity disorder, ADHD, is characterized by core behavioral symptoms of impulsivity, hyperactivity, and/or inattention. ADHD is distinguished from other types of learning disabilities in that an affected child displays behavioral problems in school. All aspects of school performance are usually disrupted. In addition to hyperactivity, children with ADHD may have specific learning disabilities. These specific learning disabilities possibly contribute. Prevalence and gender differences. Prevalence rates. The Centers for Disease Control and Prevention reports that about 5% of children in the United States are diagnosed with ADHD. Diagnoses of ADHD have steadily increased. In some jurisdictions, ADHD is applied to as many as 12% of school-aged children. Gender differences. Boys are twice as likely as girls to be affected by ADHD. ADHD may be diagnosed less often in girls in part because of symptom differences. Girls are more likely to display inattention. Girls are less likely to act out. Boys are more likely to display hyperactivity and impulsivity. Diagnostic criteria. The DSM-5 lists two main diagnostic criteria: inattention, hyperactivity, and impulsivity. Inattention. 6 or more symptoms of inattention are required in children up to age 16. 5 or more symptoms are required in adolescents 17 and older and adults. Symptoms of inattention must have been present for at least 6 months. These symptoms must be inappropriate for the developmental level. Symptoms include avoiding tasks and distractibility, inability to pay attention to details, hold attention on tasks, listen, follow instructions, organize, finish work. Hyperactivity and impulsivity. 6 or more symptoms of hyperactivity, impulsivity are required in children up to age 16. 5 or more symptoms are required in adolescents 17 and older and adults. Symptoms of hyperactivity, impulsivity must have been present for at least 6 months. The symptoms must be disruptive and inappropriate for the person's developmental level. Symptoms include fidgeting, not remaining seated, running about, talking excessively, play, take turns. Diagnostic requirements. additional diagnostic conditions also must be met. Several inattentive or hyperactive, impulsive symptoms must be present before age 12 years. Several symptoms must be present in 2 or more settings, e.g., at home, school, or work, with friends or relatives, in other activities. Clear evidence must show that the symptoms interfere with or reduce the quality of social, school, or work functioning. Developmental course of symptoms. Infancy. In infancy, hyperactive children exhibit poor and irregular sleep, they exhibit colic, they exhibit feeding problems, they do not like being cuddled or held still for long. Early childhood. Later, they are described as learning to run rather than to walk. They are described as being driven to handle and play with everything. Kindergarten. By the time they reach kindergarten, they are demanding, they are inattentive, they do not play well. With other children, people outside the home may begin to reject a hyperactive child because of his behavior. School age. By the time the child enters school, his high activity level leads to referral for assessment. His low tolerance for frustration leads to referral for assessment. His poor concentration leads to referral for assessment. His poor self-esteem leads to referral for assessment. Adolescence. By adolescence, many of these children are failing in school. 25% to 50% have encountered problems with the law. Their behavior remains restless. They withdraw from school. They fail to develop social relations. They fail to maintain steady employment. Prevalence of hyperactivity. General incidence. Hyperactivity is the most common behavioral disturbance among children. Incidence estimates vary because different definitions exist. Cultural differences in tolerance of hyperactive behavior exist. Reported rates. The American Psychiatric Association suggests a prevalence rate of between 3% and 5%. There is a higher incidence in boys than in girls. Causes and brain mechanisms. Brain and biological factors. Numerous brain imaging studies suggest wide-ranging structural and connection irregularities in people diagnosed with ADHD. The suggested causes of hyperactivity are extensive. They include brain damage, encephalitis, genetics, food allergies, high lead concentrations, various home and school environments. Frontal circuits and self-regulation. This evidence suggests that circuits in frontal brain regions impair self-regulatory behavior. Ventral frontal regions including the basal ganglia impair self-regulatory behavior. Impaired self-regulation contributes to ADHD, leads to disruption in ongoing actions, also leads to failure to learn from experience. Treatment approaches. Counseling and environment. Therapy includes counseling for the child and parents, careful structuring of home and school environments, stimulant medications, beginning in the 1960s and continuing to the present. Treatment with stimulant drugs has been popular. Brand names include Adderall, Concerta, Dexedrine, and Ritalin, among others. Non-stimulant and other drugs. Many non-stimulant drugs, including Strattera and Intuniv, are reportedly effective. Antidepressant drugs are sometimes prescribed for treatment. Effectiveness and controversy. The effectiveness of drug treatment as a long-term solution is controversial. In some countries, drug treatments are underprescribed over concerns about illegal use. In other countries, drugs are overprescribed in that the number of users exceeds the number of people diagnosed with ADHD. Mechanism and misuse. Drugs may control ADHD symptoms because they allow the person to concentrate on the task at hand. They are used as cognitive enhancers for the same reason. Consequently, prescription drugs are funneled into the underground drug market. They are used recreationally and for cognitive enhancement. Cerebral palsy. Original definition: cerebral palsy was originally defined as a disorder primarily of motor function. It was caused by brain trauma in the course of fetal development or birth. Difficulties in definition: any simple definition is difficult. Trauma can occur both prenatally and, by some definitions, within the first 5 years postnatally. Motor symptoms take many forms. They range from mild impairments in a single limb. They extend to more severe impairments that compromise movement of the entire body. Various kinds of accompanying impairments may occur. These include cognitive and emotional impairment, epilepsy, and impairment of other body functions. The causes are diverse and include blood clots, infections, and a wide range of traumatic brain injuries. Classification issues: cerebral palsy cannot accurately be called a disease, a syndrome, or even a condition. It will take a different form in each person, depending on the nature of the brain damage. The term cerebral palsy is most useful in an administrative sense. It is a category of persons who are disabled in many different ways by disorders due to non-progressive brain abnormalities. Because brain damage is the underlying cause, cerebral palsy is not curable. It is often amenable to therapy and training. It is also amenable to environmental modifications that aid the affected individual. Historical perspectives. Early description: cerebral palsy was first described in 1853 by London physician William Little. He recognized that motor dysfunction, displayed by some babies, results from abnormal parturition, delivery, results from difficult labor, results from premature birth, results from asphyxia. Recognition of permanence and associated issues. Little recognized the permanence of the disabilities, their associated intellectual impairments, their effects on personality, such as irritability and temper tantrums, their association with epilepsy, role of improper training and education. Little pointed out that these problems could be severely aggravated by subsequent improper training and education. Later definitions. Subsequent definitions of cerebral palsy have attempted to incorporate many other symptoms that are not strictly motor. Incidence and classification. Incidence. The incidence of cerebral palsy is estimated at about 3.5 per 1,000 births. The greatest influence, prematurity, can increase incidence 100-fold. The numbers of males and females afflicted are about equal. Levels of impairment. Estimates of the degree of impairment suggest the following: about 10% require no special services. About 65% need services on an occasional basis. About 25% need special schooling or custodial care. Motor symptom categories. When cases of cerebral palsy are categorized by motor symptoms, the distribution is as follows: about 50% of persons with the disorder are spastic. Their limbs resist being moved. About 25% are athetoid. They make slow involuntary movements. About 10% are afflicted with rigidity. Muscles around joints are stiff. About 10% are ataxic. They have difficulty making voluntary movements. Causes and neurological basis. Neurological lesions. Lesions of the corticospinal tracts, basal ganglia, brainstem, and cerebellum are presumed to be responsible for the motor disorders. Establishing clear-cut relations between lesions and clinical findings has proved difficult. Broad impact of lesions. Symptoms are not limited to motor function. They can include any function controlled by the brain. Lesions may include any part of the nervous system. Potential causes of cerebral palsy, hereditary causes, static, familial athetosis, familial paraplegia, familial tremor, progressive, demyelinating diseases of viral or undetermined origin. Chromosomal breakages are rare in cerebral palsy. Disorders of metabolism are rare in cerebral palsy. Congenital causes, acquired in utero, infections, rubella, toxoplasmosis, cytomegalic inclusions, herpes simplex, other viral or infectious agents, maternal conditions, maternal anoxia, carbon monoxide poisoning, strangulation, anemia, hypotension associated with spinal anesthesia, placental infarcts, placenta abruptio, other prenatal factors. Prenatal cerebral hemorrhage, maternal toxemia, direct trauma, maternal bleeding, diathesis, prenatal anoxia, twisting of the cord, kinking of the cord, miscellaneous, toxins, drugs. Perinatal causes, obstetrical, mechanical anoxia, respiratory obstruction, narcotism due to oversedation with drugs, placenta previa or abruptio, hypotension associated with spinal anesthesia, breech delivery with delay of the aftercoming head, trauma, hemorrhage associated with dystocia, disproportions and malpositions of labor, sudden pressure changes, precipitate delivery. Caesarean delivery, complications of birth, small for date babies, prematurity, immaturity. Dysmaturity, postmaturity, hyperbilirubinemia and isoimmunization factors, kernicterus due to Rh factor, ABO incompatibility, hemolytic disorders, respiratory distress disorders, syphilis, meningitis, other infections, drug addiction reactions, hypoglycemic reactions, hypocalcemic reactions. Postnatal causes, infancy, trauma, subdural hematoma, skull fracture, cerebral contusion, infections, meningitis, encephalitis, brain abscess, vascular accidents, congenital cerebral aneurysm, thrombosis, embolism, hypertensive encephalopathy, sudden pressure changes, toxins, lead, arsenic, coal tar derivatives, anoxia, carbon monoxide poisoning, strangulation. High-altitude anoxia, deep pressure anoxia, hypoglycemia, neoplastic and late neurodevelopmental defects. Tumor, cyst, progressive hydrocephalus. Treatment and quality of life. Treatment approaches. There are no specific treatments for cerebral palsy. Physical therapy has been used. Creating small lesions to the spinal cord has been used. The injection of Botox to immobilize muscles has been used. These approaches aim to relieve muscle cramps. They also aim to promote movement in immobilized limbs. Quality of life factors. The most important factors that improve the quality of life of affected individuals are environmental changes. Environmental changes improve physical care. They enhance educational opportunities. They encourage social well-being. Hydrocephalus. Causes and mechanisms of hydrocephalus. General characteristics. Hydrocephalus is characterized by increased volume of the cerebrospinal fluid, CSF. Hydrocephalus can be caused in two ways. Atrophy-related cause. Enlarged ventricles can be a secondary result of shrinkage or atrophy of surrounding brain tissue. This form is more likely to develop in adults. Obstruction-related cause. Obstruction in the flow of CSF results in a buildup of pressure in one or more ventricles. This eventually causes their expansion. This is the more typical cause of hydrocephalus. It occurs especially in infants. Uncertainty of overproduction. Whether a simple overproduction of CSF is ever a cause of hydrocephalus is uncertain. Circulation and flow of cerebrospinal fluid. The ventricular system in a healthy brain. In a living brain, the ventricles are filled with CSF. The usual volume in an adult is only about 130 milliliters. About 1/3 is in the spinal cord's great lumbar cistern. Production of CSF. The CSF is made by the choroid plexus in the ventricles. Most of it is made in the lateral ventricles. Pathway of CSF. From the lateral ventricles, CSF flows through the interventricular foramina, windows, of Monro into the third ventricle. From the third ventricle, it flows through the cerebral aqueduct. It then flows into the fourth ventricle. CSF finally escapes through 3 little holes in the roof of the fourth ventricle. These holes are the 2 laterally located foramina of Luschka and the medial foramen of Magendie. The mnemonic is lateral, Luschka, medial, Magendie. The fluid then enters the subarachnoid space beneath the arachnoid membrane of the meninges and spinal cord. It is absorbed into the veins and carried away by the bloodstream. Obstruction and clinical consequences. Blockages of CSF flow. Circulation in the ventricles can be blocked at either interventricular foramen. This causes increased pressure followed by the expansion of either lateral ventricle. CSF can also be blocked at the level of the cerebral aqueduct. This blockage causes hydrocephalus of the first 3 ventricles. CSF can also be blocked by closure of the foramina in the roof of the fourth ventricle. This produces hydrocephalus of the entire ventricular system. Rapid obstruction. Any sudden obstruction of CSF flow causes a rapid rise in intracranial pressure. It causes ventricular dilation. It finally causes coma. Gradual obstruction. A gradual obstruction, such as by a tumor, causes a less rapid increase in pressure and consequent dilation. The symptoms may include the gradual appearance of visual disturbances, palsies, dementia. Other conditions. Infant hydrocephalus. Incidence. Infant hydrocephalus is characterized by a conspicuous enlargement of the head. Infant hydrocephalus usually develops during the first few months of life. Infant hydrocephalus affects as many as 27 of 100,000 newborn babies. Causes. In about 14% of these cases, a malformation impedes CSF circulation. Most other cases result from inflammation or trauma. About 4% are due to tumors, effects of ventricular distension. As the ventricles distend, they push the cerebral hemispheres into a balloon shape. Because the skull bones of an infant are not yet fused, continued pressure causes the head to expand in all directions. Consequences for intelligence. If expansion damages the cortex, intelligence may be impaired and dementia may result. If the cortex is not damaged, intelligence may be unimpaired. Intelligence may be unimpaired even after the cortex has been stretched into a sheet of tissue less than a centimeter thick. Treatment and prognosis. Treatment: hydrocephalus can be treated with some success by inserting a valve into one lateral ventricle. A tube passes into a jugular vein to drain into the cardiac atrium. Prognosis: if untreated, hydrocephalus often causes death, severe mental or motor disabilities. Autism spectrum disorders. Origins and early descriptions of autism. Use of the term. The term autism was first used by Leo Kanner and Hans Asperger in the 1940s. Characteristics of children described: these were individual children without obvious signs of focal cerebral disease. They displayed such symptoms as severely impaired social interaction, a bizarre and narrow range of interests, language and communication abnormalities, preserved intellect in some cases, range of abilities, some are severely impaired, others can function on their own, still others have exceptional abilities in some areas, such as music, art, or mathematics. Autism spectrum disorder, ASD, broad definition. The disorder is now referred to as autism spectrum disorder, ASD. This is to include children with either mild or severe symptoms. Related disorders. Other rare, very severe disorders are included in the autism spectrum. Rett syndrome is included, and it affects mainly females. Childhood disintegrative disorder is included, and it affects mainly males. Alternative diagnosis. If a child's symptoms do not meet the specific criteria for ASD, the diagnosis is pervasive developmental disorder not otherwise specified, PDD-NOS. Prevalence and incidence of ASD. General prevalence. ASD is estimated to affect as many as 1 to 3.5 of every 1,000 children. ASD is 4 times as prevalent in boys as in girls. ASD has no known racial, ethnic, or social boundaries. Reported increase. Its incidence is reported to have increased dramatically in the past 30 years. Ashley Wazana and her colleague calculate that the apparent increase is due to methodological factors. These factors include better reporting, earlier diagnosis, early development and behavioral symptoms of ASD, infant behavior. Many infants on the autism spectrum behave oddly from birth. They avoid physical contact with caregivers by arching their backs, going limp when held. Symptom onset. Approximately 1/3 of children diagnosed with ASD develop typically until between 1 and 3 years of age. Caregivers begin to notice symptoms at this age. Common symptoms. Common symptoms include a failure to interact socially, and an insistence on sameness. One possible reason for insistence on sameness may be an inability to understand and cope with novel situations. People affected by ASD may exhibit repeated body movements, such as hand flapping and rocking. They may exhibit unusual facial movements and features, unusual responses to people, unusual attachments to objects, resistance to any change in routine. In some cases, aggressive or self-injurious behavior or both are seen as well. Asperger's syndrome. General features. A less severe condition of withdrawal in children is Asperger's syndrome. Although withdrawn, these children exhibit early speech and good grammar. They also exhibit narrow, repetitive play, poor peer relations, a need for routine and sameness, areas of excellence. They may excel in some aspect of behavior, such as reading, calculations, music, or art. Hyperlexia in Asperger's syndrome. Definition and characteristics. Hyperlexia describes unusual reading ability in otherwise cognitively impaired persons, such as children with Asperger's syndrome. Hyperlexia is marked by precocious development of reading abilities between the ages of 3 and 5 years. Often these children teach themselves to read. Reading challenges. Reading may not be completely fluid because many of those affected have articulatory defects, prosodic irregularities of intonation and rate of speech. Generally, reading comprehension is impaired. Associated symptoms. Children with hyperlexia show emotional withdrawal, occasional echolalia, which is pathological repetition of others' speech, symptoms of autism. Exceptional abilities in Asperger's syndrome. Memory abilities. Those who exhibit Asperger's syndrome can develop exceptional memory abilities. These abilities may include an unusual ability to remember words, television shows, names of streets, the weather, and birthdays. Commonly displayed skills. Commonly displayed skills include calendar calculations. Some can tell the day of a person's birthday in any year of a 1,000-year period. Commonly displayed skills include mathematical ability, musical ability, including the ability to play new pieces of music after hearing them once, sculpting, drawing, peculiar feats of memory. Peculiar feats of memory may include recalling what the weather was like on every day of the person's life, retention of the names of all visitors ever received and the dates of their visits, recalling the date of every burial in a parish in a 35-year time span, recalling the names of all the attendees. Savant syndrome. Historical description. Related to Asperger's syndrome is savant syndrome. Savant syndrome was first described by John Langdon Down in 1887 as idiot savant syndrome. Nature of abilities. Affected persons have a narrow range of special abilities. A common symptomatic triad is retardation, blindness, and musical genius. Etymology of the term. The oxymoronic idiot savant was coined by combining the word idiot with savant. Idiot was at one time an accepted label for a subcategory of intellectual disability. Savant means knowledgeable person. The term has endured despite its now pejorative connotation. Characteristics of savants. Savants are characterized by mental challenges resulting from a developmental disability or mental illness. These mental challenges are combined with a talent that far exceeds their other abilities and the abilities of the general population. Such persons are called talented savants or prodigious savants. Prevalence and special skills. The syndrome affects males about 6 times as frequently as females. The special skill can appear quite suddenly and disappear equally quickly. Brain abnormalities and autism. Correlation between abnormalities and impairments. Extensive research shows that brain abnormalities in various types of ASD correlate with the degree of impairment displayed by an autistic person. Impairments in explicit memories, memories for daily events, might be related to temporal lobe abnormalities. Impairments in implicit memory, learned skills and conditioned responses, might be related to parietal and cerebellar abnormalities. Developmental processes and head size. Retrospective studies show that head size pre-birth is normal in autistic children. By age 1, head and brain are larger than normal. This finding suggests that plastic processes related to development, including cell division, cell loss, and synaptic pruning, are atypical. Such changes in developmental processes would lead to widespread brain abnormalities. Specific structural hypotheses, von Economo-neurons. John Ullman and his colleagues proposed that large frontal cortex cells called von Economo-neurons fail to develop normally. This results in abnormal social development in affected persons, brainstem development, and genes. Patricia Rodier suggests that one cause of autism may be an abnormality in the expression of genes central in brainstem development. She found that an area in the caudal part of the pons is small in autistic subjects. Brainstem development and genes. Several nuclei in this area, including the facial nucleus, which controls facial musculature, are small or missing. Top. Many autistic children have subtle facial abnormalities that may be due to abnormalities of the facial nerve. Bottom. Perhaps mutation of the HOSA1 gene, which plays a role in brainstem development, or interference in the expression of this gene, is responsible for some cases of autism. Cerebellum and behavioral features. Conditioned responses. Evidence that the cerebellum controls conditioned responses suggests that the desire for sameness and avoidance of novelty characteristic of autism also may be related to cerebellar abnormality, habituation, and sensory response. One feature of conditioned learning is habituation, in which a response to a stimulus weakens with repeated presentations. Absent the ability to habituate to ongoing events, a person may find such stimuli especially noxious. A person may avoid such stimuli in favor of maintaining sameness. This theory could explain, for example, why people with autism report that the sound of traffic, to which most people quickly habituate, remains for them frighteningly loud. Cortical networks and connectivity. Hypothesis of cortical thickness. In an attempt to define networks in the autistic brain, Feng-Shi and colleagues, 2013, hypothesized that cortical thickness provides a good index of the brain's modular organization. Regions of similar cortical thickness should group together as functional modules. Identified modules. They identified 3 modules: frontal, parietal, and temporal, in the cortex of preadolescent children. Connectivity findings. They estimated the connectivity between and within these modules. They found fewer connections between modules in the autistic group. They found increased within-module connections in the frontal module. Scher's group proposes that the frontal module in the autistic group both talks to itself more and talks less with the rest of the brain than in the control group. Implications for individual symptoms. Although this analysis presents averaged results for a large group of individuals, future analyses of individual cases could well provide insights into the symptoms of individual cases of ASD. Genetic influence on ASD. ASD is proposed to be under strong genetic influence. In some families, autism is highly heritable. In others, heritability is lower. Variable concordance is reported for identical twins. A low-end estimate of concordance is about 0.5. This estimate, although high, also points to the contribution of epigenetic factors. Gene domain DUF1220, a fascinating line of inquiry into the gene contribution to ASD implicates a gene domain of unknown function, DUF1220, located in the long arm of chromosome 1. DUF1220 is a base sequence, likely forming a gene, which features a large number of copies. DUF1220 is unstable, and copy number can vary from around 55 to 90. The average number of copies is about 70. In this respect, DUF1220 is like the CAG base pair repeats related to Huntington's disease. rather than 3 base pairs repeating. An entire gene repeats. A high number of DUF1220 repeats is correlated with the symptoms of ASD. Evidence linking DUF1220 to brain development. Comparative evidence across species. Copy number is found to increase in the primate lineage along with increases in brain size. An especially large increase is found in modern humans. Brain size conditions. Copy number is found to be smaller in humans who display microencephaly, and larger in humans who display macroencephaly. Brain cell division. Investigations of the effects of DUF1220 on brain development suggest that it is related to brain cell division. With higher copy number, more brain cells are produced. Evolutionary implications and theoretical unknowns. Evolutionary advantage and side effect. The Davis Group suggests that the instability of DUF1220 has allowed the evolution of a large human brain. This evolution has the consequent deleterious side effect of autism, impact on neurons. In ASD, the increased DUF1220 copy number causes the production of excess numbers of neurons. If not eliminated, these neurons have poorly formed connections, remaining unknowns. Some unknowns remain in the theory, including why copy number changes occur. Another unknown is why high copy number does not always produce a brain characteristic of ASD. Explanatory strength. The theory does explain many autistic individuals' large brains, their highly variable symptoms, ASD's genetic basis. Environmental and viral factors in ASD. Viral causes. Other evidence supports a viral cause for ASD. Women have an increased risk of bearing an autistic child after exposure to rubella in the first trimester of pregnancy. For example, environmental toxins. Some suspect that industrial toxins and other environmental pollutants can cause autism. The evidence for these causes is uncertain. Vaccines and mercury. Concern is voiced as well that mercury used as a preservative in vaccines, and vaccines themselves, can trigger ASD. No scientific support for this view has emerged. Many well-done, large-scale studies fail to show a link between mercury and autism. Fragile X syndrome. Fragile X syndrome and its relationship to ASD, prevalence and inheritance. Fragile X syndrome, a common inherited cause of mental impairment and ASD, affects about 1 in 2,000 males and 1 in 4,000 females. About 1 in 259 women and 1 in 800 men carry the Fragile X gene and could pass it on to their children. Clinical features. Fragile X syndrome is characterized by facial abnormalities and by mental disabilities ranging from subtle learning disorders to severe intellectual impairment. It is associated with attention deficits, hyperactivity, anxiety, and unstable mood, and behaviors characteristic of ASD. Physical characteristics include a long face, large ears, flat feet, and hyperextensible joints, especially fingers. Boys are typically more severely affected than girls. Most boys with Fragile X syndrome are typically learning disabled compared with only about 1/3 of affected girls. Genetic basis of Fragile X syndrome, FMR1 gene and protein function. Fragile X syndrome is caused by an abnormality of the FMR1 gene located on the long arm of the X chromosome. When functional, FMR1 encodes a protein, FMRP, that participates in translating mRNA into protein in neurons. including in their axons and dendritic spines. The protein participates in synapse formation and maturation. The protein is related to the production of receptors for glutamate and GABA. Mutation. Mechanism. The mutation occurs in a stretch of CGG base pair repeats in the X chromosome DNA. This sequence of repeats is prone to increase in length as it passes from generation to generation. When the number of CGG repeats exceeds a critical level of about 200, their expanded area encourages methylation. This methylation extends to blocking the promoter region of the FMR1 gene. This process halts production of FMRP. Neural abnormalities. Examination of neurons in affected persons at autopsy shows that dendritic spines are poorly formed and more numerous than typical. Thus, the protein encoded by the FMR1 gene may be required for healthy development and elimination of synapses. MRI scans of children with Fragile X syndrome show cortical thinning. MRI scans show an unusually small caudate nucleus. MRI scans show an increase in ventricular size, which suggests a general loss of brain cells. Sex differences and potential genetic therapy. Female symptom expression. Symptoms in females are generally less severe than those in males because females have two X chromosomes. If one is abnormal, the other is usually able to manufacture the necessary protein. Implication for therapy. This difference suggests that, in theory at least, if a normal copy of the FMR1 gene could be inserted into brain cells, neuronal abnormalities could be reduced. Animal models and experimental approaches. Mouse models. A number of animal models of Fragile X syndrome have been produced. The knockout FMR1 mouse model is the most extensively studied. These mice are prone to epilepsy, learning impairments, and hyperactivity, symptoms that mimic human Fragile X symptoms. Gene replacement therapy has been explored in neurons cultured in a dish. Gene replacement therapy has been explored in a mouse that had previously lacked the Fragile X gene. Pharmacological treatments. Because FMRP affects both glutamate and GABA receptors, experimental studies and clinical trials have been conducted with drug antagonists of glutamate receptors or agonists of GABA receptors. The former treatment is reportedly beneficial to a subset of patients. The latter treatment reportedly improves some social deficits in patients. Thus, some hope of treatment success exists for people affected by Fragile X syndrome. Fetal alcohol spectrum disorder. Definition and classification. Origin of the term. The term fetal alcohol syndrome was coined by Kenneth Jones and David Smith in 1973. It describes a pattern of physical malformation and intellectual impairment observed in children born of alcoholic mothers. Broader classification. These disorders are now included under the umbrella of fetal alcohol spectrum disorder, FASD. Physical and neurological characteristics of FASD. Facial and brain irregularities. Children with FASD may have irregular facial features, including a smooth philtrum, the fissure below the nose, a thin upper lip, short palpebral fissures, the distance across the eyelids. They also have a range of brain irregularities, from small brains with abnormal gyri to brains of typical size with abnormal clusters of cells, and misaligned cells in the cortex. Other physical characteristics. Among their physical characteristics are small stature. Another characteristic is a tendency to be thin. Behavioral symptoms of FASD, learning and intelligence. Related to the anatomical anomalies observed in FASD are certain behavioral symptoms. Children commonly display varying degrees of learning disabilities. They also display lowered intelligence scores, hyperactivity, and social problems. They also display hyperactivity, other social problems. Prevalence and risk populations, general recognition and incidence. The recognition of FASD stimulated widespread interest in the effects of alcohol consumption by pregnant women. Pronounced FASD is found in the offspring of approximately 6% of alcoholic mothers. Its incidence in different geographic regions varies widely. This depends on the pattern and degree of alcohol abuse in those locations, population-specific risks, and Streisguth and Paul Connor suggest that about 1 in 700 to 1 in 100 newborns in the United States have FASD, an especially high incidence in childcare settings and among prison populations suggests that these are at-risk populations. Factors influencing severity of FASD, range of abnormalities. Fetal alcohol syndrome is not an all-or-none diagnosis. Alcohol-induced abnormalities can range from hardly noticeable physical and psychological effects to full-blown FASD. Timing, frequency, and quantity of alcohol. Severity is related to when alcohol was consumed during a pregnancy, how much alcohol was consumed, how frequently alcohol was consumed, many other individual factors. Critical periods and binge drinking. The worst effects occur if drinking takes place in the first 3 months. This unfortunately may be a time when many women do not know that they are pregnant. Severe FASD is also more likely to be caused by binge drinking. Binge drinking produces high blood alcohol levels. Other contributing factors. Other factors related to a more severe outcome are poor maternal nutrition. Other factors also include use of other drugs, including nicotine. Safe levels of alcohol and recommendations. Central question. A major and complex question FASD raises is how much alcohol is too much to consume during pregnancy. The effects of alcohol on a fetus depend on so many factors. Recommendations for safety. To be completely safe, it is best not to drink at all in the months preceding pregnancy as well as during it. This conclusion is supported by findings that as little as 1 alcoholic drink per day during pregnancy can lead to decreased intelligence test scores in offspring. Male consumption. This advice extends to males as well as females. This is because it is likely that if a male consumes alcohol, his partner does too. It is also because alcohol may produce epigenetic changes in sperm that affect fetal development. Broader lessons and social considerations. General lessons. FASD, in its full-blown and milder forms, teaches important lessons. Alcohol is a widely used drug that poses risks when used inappropriately. When used in moderation, alcohol may have health benefits. Even so, women who are pregnant should completely avoid alcohol. At-risk women. Women most at risk for bearing FASD babies often are poor and not well educated, with alcohol consumption problems that predate pregnancy, and little access to prenatal care. They often are unaware of the dangers that alcohol poses to a fetus. They do not understand the need to abstain from drinking while they are pregnant. Mechanisms of alcohol's effects in FASD, general and epigenetic effects. Among the suggestions related to mechanisms by which alcohol produces its characteristic effects are general effects on cell division and maturation. Other suggestions are epigenetic effects, potassium channel hypothesis, An interesting idea relates to possible effects on a potassium channel called KIR 2.1. KIR 2.1 allows K1 to move freely across the cell membrane. It is important for maintaining a normal resting potential across both neuronal and non-neuronal cell membranes. When the channel is blocked, downstream effects on cell metabolism result in apoptosis, cell death. Such effects may account for physical and brain abnormalities seen in FASD. Supporting evidence. Supporting evidence for KIR 2.1's role in FASD is that mutations in genes that produce it produce physical and behavioral symptoms that resemble FASD. Knockouts of these genes in mice also produce physical and behavioral symptoms that resemble FASD. Alcohol does have an inhibitory effect on KIR 2.1 channels. This suggests that their dysregulation contributes to development of FASD. 4. Developmental influences on neurodevelopmental disorders. Structural damage and toxic effects. Structural brain damage and learning disorders. Initial hypothesis. When a childhood learning disorder, dyslexia is an example, resembles a symptom seen in brain-damaged adults, it is only natural to wonder whether structural damage of a similar nature causes the learning disorder. Such structural damage could be birth trauma, encephalitis, anoxia, an early childhood accident, limited applicability. This no doubt is the case for a small minority of affected children. Many neurological symptoms associated with brain damage in adults are not typically observed in children. Example of symptom differences: children with developmental dyslexia do not have hemianopia, blindness in half of the visual field, or scotomas, blind spots in the visual field. These symptoms are present in a large percentage of brain-damaged adults with dyslexia. Neuroimaging evidence. The results of EEG and CT scan studies usually do not support a structural damage hypothesis. Abnormal EEGs similar to those correlated with known brain damage do not correlate consistently with neurodevelopmental disorders. Subtle brain changes and environmental factors. General subtle influences. Subtler changes in brain structure can be produced in many ways. Possible causal factors include poor nutrition, drug use, exposure to environmental contaminants, environmental toxins. Clearly, exposure to environmental toxins such as mercury and some other metals can lead to learning disorders. Evidence from Jessica Reyes. As is reviewed by Jessica Reyes, it is possible to infer causal relations between environmental toxins and the incidence of learning disabilities and crime. She notes increases in school performance and decreases in violent crime, following the removal of lead from automobile gasoline in the 1970s. Challenges in causal identification. Nevertheless, it is generally hard to identify both the presence and the extent of toxins retrospectively. It is equally difficult to identify a toxin as a causative agent in a neurodevelopmental disorder. Hormonal effects. The Geschwind-Galiberta theory. Hormonal influences on neurodevelopmental disorders. Male-female incidence differences. The higher incidence of neurodevelopmental disorders in males than in females raises the question of whether hormones that differentiate the male brain during development contribute. Norman Geschwind and Albert Galiberta propose that gonadal hormones may affect brain development and learning. Anatomical basis of the hypothesis. The seat of their hypothesis lies in the observation that the planum temporale is asymmetrical. The planum temporale is Wernicke's area in the auditory cortex, which represents speech in the left hemisphere. The planum temporale is larger on the left and smaller on the right in most right-handers. This typical anatomical asymmetry is considered the basis of an underlying neural asymmetry. This asymmetry gives rise to the left hemisphere's dominance in language. Because males show greater deviance from this asymmetrical pattern, it is possible that testosterone plays a role. The Geschwind-Galiberta theory of brain development. Embryonic testosterone effects. During embryonic development, the male fetal gonads produce high levels of testosterone. These levels are comparable to levels in adult males. The Geschwind-Galiberta theory proposes that the embryonic surge of testosterone delays left hemisphere development. This delay allows the right hemisphere both space and time for greater development. Thus, males in general have some comparatively better developed areas in the right hemisphere. These areas presumably would endow them with excellent spatial skills. Positive and negative outcomes. If the testosterone-induced asymmetry produces some particularly large right hemisphere areas, special abilities may result. Special abilities include precocious mathematical reasoning ability. Alternatively, perhaps testosterone also produces some casualties. These casualties are characterized by brain abnormalities and learning disabilities. Effects on the immune system. The theory proposes that testosterone also affects immune system development. The consequence is an increase in susceptibility to autoimmune disorders. These disorders include migraines, allergies, asthma, thyroid disorders, and ulcerative colitis. This explains their high incidence, both among males in general and among males with exceptional abilities. Broader implications of the theory, language and spatial skills. The appeal of the Geschwind-Galiberta theory is that it accounts for the general observation that females tend to do better than males at language-related tasks. Males tend to do better than females at spatial tasks, learning disabilities, and precocity. The theory also accounts for the high incidence both of precocity and of learning disabilities among males. The proposed rightward shift in cerebral dominance further suggests an explanation for the high incidence of left-handedness among the precocious and among the learning disabled. Immune disorders and gender differences. Because testosterone's effects on the brain will in some ways parallel its effects on the immune system, the theory accounts for the high incidence of autoimmune disease in the precocious and learning disabled male populations. Additionally, the theory allows for deviations in hormonal functions to produce increased incidences of learning disorders, precociousness, left-handedness, and autoimmune disorders in females. Testability. Another appealing aspect is that the theory is testable. The theory can be explored using animal models. Neuropathological evidence in dyslexia. Early case study. The first dissection of the brain of a person with a reading disability was performed on a 12-year-old boy who died of cerebral hemorrhage. The boy's intelligence had tested in the normal range. In school he had been impaired in arithmetic, writing, and reading. The autopsy revealed atypical gyral patterns in the parietal lobes. An atrophied corpus callosum, neurons that should have migrated to the cortex within the underlying white matter. Galiberta's later findings. Later, Albert Galiberta's group, 2006, examined the brain of a 20-year-old man who had had a reading disability despite average intelligence. Visual inspection showed nothing irregular. Microscopic examination revealed several anomalies: polymicrogyria, numerous small convolutions, and other architectonic abnormalities were found in left frontal and parietal cortex. Subcortical abnormalities in the medial geniculate and the lateral posterior nuclei of the thalamus were discovered as well. Since the original study, this group has reported similar findings in other cases. Hormones and ASD, correlation with prenatal hormone levels. More recent support for the idea that high levels of gonadal hormones can alter brain development comes from studies that correlate serum hormone levels prenatally with the subsequent diagnosis of ASD. Implications for ASD. This relationship has led to the suggestions that in some respects, ASD symptoms are related to exaggerated male brain features. The excessive expression of sex hormones alters the epigenetic profile of the developing brain. Environmental deprivation. Consequences of environmental deprivation. General effects. Environmental deprivation can have long-lasting consequences for physical and intellectual function. Children raised in orphanages with adequate physical care but inadequate social stimulation fail to thrive. They fall below age norms in physical development. They fall below age norms in intellectual development. Romanian orphanages. In the 1970s, the communist regime then governing Romania outlawed all forms of birth control and abortion, the consequence of the hundreds of thousands of unwanted pregnancies that resulted were unwanted children. These children were placed in orphanages where the conditions were appalling. Adoption and recovery outcomes. Improvements after adoption. After the communist government fell and the outside world moved to intervene, hundreds of these children were placed in adoptive homes throughout the world. Initially malnourished and small in size, they improved spectacularly in their adoptive homes. Their average height and weight became almost normal. Most achieved healthy motor and cognitive development. Persistent difficulties. A significant number were learning disabled. Many had psychosocial problems. These included difficulty in developing secure attachments with adults and healthy relations with peers. Age at adoption. Children who were adopted before 6 months of age had significantly better outcomes than did those adopted at older ages. Continuing relevance of environmental deprivation. International adoption. People in post-industrial societies continue to adopt children from developing countries. These children have been subjected to various degrees of deprivation. Deprivation in advanced countries. Even in the most economically advanced countries, many children suffer varying degrees of deprivation and abuse. Accordingly, environmental deprivation continues as a leading cause of learning disorders. Importance of early intervention. Interventions work best within the first 3 years of life. For many children who suffer deprivation at older ages, intervention is less effective. The birthday effect. The birthday effect and its impact on development, definition and initial findings. A subtle variant on environmental deprivation is called the birthday effect. The birthday effect is the influence of birth date on subsequent success at sports or school. The finding comes from studies undertaken by Roger Barnsley and his colleagues of birthdays of North American hockey players. In senior hockey leagues, the investigators found a negative correlation between birth month and number of players. More than 30% of players had birth dates in the first quarter of the year, 16% were born in January, fewer than 15% had birth dates in the last quarter of the year, 5% were born in December. A disproportionate number of superstars had first-quarter birthdays. Development of the effect in sports. This birth discrepancy is not present in beginning hockey leagues. It emerges progressively as players advance through the leagues. The explanation appears straightforward. Players enter the most junior league according to age. Children must be 8 years old between January 1st and December 31st of the year in which they enter mite hockey. Equal numbers of children born in each month enter. Children born in January enter hockey almost a year earlier than children born in December. Children born in December, in effect, have had to wait a year. The younger, smaller children are at a developmental disadvantage from the outset. They receive less playing time and reinforcement. They are more likely to drop out. In sports not regulated by entrance age, such as high school football, parents use the birthday effect to advantage. Parents delay the age at which their children start school. Educational implications. Research on the effects of relative age on educational achievement produces similar results. Lars Lehn and his co-workers find, as parents who understand the birthday effect know, that children entering school at a younger age perform at a significantly lower level than do their older classmates. Children entering school at a younger age have more emotional problems. Throughout schooling, socio-emotional skills are an important prerequisite for optimal learning. Preterm birth variation. An interesting variation on the birthday effect is documented for children born preterm. Those enrolled in school based on their actual birthday do not perform as well as preterm children who enter school based on their expected birthday. The expected birthday is the due date projected for full-term birth. Maturational age, although not a primary factor in learning disabilities, can worsen performance of learning-disabled children. 5. Adult outcome of neurodevelopmental disorders. Optimistic outcomes for children with neurodevelopmental disorders. Private school study by McDonald Critchley. The variety of views on outcomes for children with neurodevelopmental disorders range in level of optimism. In the most optimistic outcome study, reported by McDonald Critchley, 20 dyslexic boys attended a private school and received special instruction using training methods. As adults, 2 became medical doctors, 2 became college professors, 1 became a lawyer, 2 became research scientists, 6 became owners or managers of businesses, 1 became a school principal, 3 became teachers, 1 became an actor, 1 became a factory foreman, 1 became a skilled laborer. Reports in the popular press. The popular press periodically reports similar, though perhaps not so absolute, successes at various private schools for learning-disabled children. Pessimistic outcomes in broader studies. Findings from Ottfried Spreen. Most outcome studies do not report such optimistic conclusions. The most thorough are frankly pessimistic about academic outcomes. Ottfried Spreen examined the progress of 203 learning-disabled people and healthy, age-matched peers over a long period. The study used assessments, personal interviews, parental interviews, and other observations. He reports that the learning-disabled group suffered through a miserable and usually short school career. They then experienced a miserable social life full of disappointments and failures. They also had a relatively poor chance of obtaining advanced training and skilled employment. They did not, however, have a higher incidence of juvenile delinquency or psychiatric problems than the general population. Differences in perceptions between parents and affected individuals. The disabled group and their parents were largely in agreement concerning factual information. Parents tended to regard learning disabilities as having had more serious effects on the well-being, happiness, and social interaction of their children than were reported by the disabled people themselves. Long-term consequences of learning disabilities, childhood memories, and school experiences. The affected people's memories of their childhood were less detailed than the control people's. As subjects aged, they developed firmer plans for their future and made better occupational adjustments. They also gave increasingly negative descriptions of their school experiences, gender differences, and health impacts. The eventual social adjustments of the females were worse than those of the males. The effects of learning disabilities early in life have negative consequences on physical as well as mental health in adulthood. Educational and counseling approaches. Importance of individualized assessment. To summarize, careful assessment in evaluating the particular cognitive deficits of each learning disabled child is invaluable. After problem areas are identified, specialized teaching programs can be devised to circumvent impairments. There may be little point in trying to teach a given child a particular skill that he or she is clearly not capable of learning. Perhaps the educational program for that child should instead be directed toward acquiring skills that can be used to gain employment. Role of counseling and support. Counseling is an important part of the educational process, both for the learning disabled child and for the parents. It should focus not only on overcoming negative attitudes toward the educational system but also on understanding the child's unique challenges. It should focus on devising strategies for circumventing them if possible. Because learning disabilities experienced early in life have lifelong consequences, counseling and support should be directed accordingly toward adult adaptation. Influence of personalized attention and practice. Finally, we cannot overemphasize the influence of personalized attention and practice. Learning takes time and repetition. Even small increments in skill acquisition can have beneficial consequences.